None of us are strangers to cervical adenopathy as head and neck radiologists, general radiologists. And what I'm going to talk about today is not, anything different, but just an overview, a review of, what are the different causes of cervical lymphadenopathy, what are the different features and when to call adenopathy and talk about adenopathy in terms of individual cancers. So I'll start my talk with, showing three cases. On the first case on our left-hand side, I'm showing this lymph node, and I'll be wondering which level lymph node that is. On the second picture in the middle, we look at that lymph node, it looks small, but we are left wondering, is that lymph node normal or abnormal? And then we have this lymph node on our right-hand side, and yeah, and we wonder, does that enlarged lymph node upstage cancer or not? So with these three simple pictures, we have three very simple objectives for our talk today. We are going to be reviewing the lymph node levels in the neck. We are going to be discussing the features of lymphadenopathy, when do we call cervical lymphadenopathy, and then we are going to be discussing anatomic features for, that are pertinent to individual head and neck cancers. So let's start with reviewing the different levels of the cervical lymph nodes. So cervical lymph nodes, of course, we know we have level 1 through 7 lymph nodes. That's the level system, which has level 1A, and B, 2A and B, 5A and B, and then we have 3, 4, 6, and 7. And then we have several lymph node groups in the neck that are not included in that level system. So we have named lymph nodes. We have the occipital lymph nodes, retropharyngeal lymph nodes, facial lymph nodes, parotid and periparotid lymph nodes, mastoid or retromastoid lymph nodes, superficial cervical, and very important Delphian lymph nodes. So all these, this slide really encompasses all the lymph nodes that we see in the head and neck region. So when we talk about the different lymph node levels, it's very important to know the different landmarks that divide these lymph nodes. So with this slide, I'm going to be talking about the different anatomic landmarks that are used that are very important in dividing these lymph nodes into these different levels. So on the sagittal image here on my left-hand side, we have the levels starting from the skull base. So supero-inferiorly, we have the skull base at the top. Then we have the hyoid bone. Then down below, we have the inferior margin of the cricoid cartilage. So that's very important to remember that when we are talking about the cricoid cartilage, we are talking about the inferior margin of the cricoid cartilage. Then we have the suprasternal notch or the clavicle. So these are the supero-inferior landmarks, anatomic landmarks that will be important, as you will see in subsequent slides, for dividing these lymph nodes into different levels. Then anteroposteriorly, we have several landmarks. So anterior most landmark is the anterior belly of the digastric muscle. Right here, we see the anterior belly of the digastric muscle. And the medial margin of this anterior belly of the digastric muscle is one of the anatomic landmarks that are used. Then we have the posterior margin of the submandibular gland. So right here, this is the submandibular gland, and the posterior margin of the submandibular gland is another landmark that we use to divide these lymph nodes. Then we have the posterior margin of the sternocleidomastoid muscle, and then anterior to that, we have the internal jugular vein that will be used in dividing these lymph nodes. Then side to side or laterally, we have the medial margin of the internal carotid arteries that will be used to divide these lymph nodes. Then, so how do we use these different landmarks? So again, if we look at this slide, we have these different landmarks, and these different landmarks will be used to level out these lymph nodes. So let's see how we use these landmarks to divide lymph nodes in the neck. So, the first landmark that I will be talking about is the posterior margin of the submandibular gland. So, anterior to the posterior margin of the submandibular gland are the level 1 lymph nodes. So, any lymph node that is anterior to the posterior margin of the submandibular gland is a level 1 node. Now, as we saw in a previous slide, level 1 lymph nodes are divided into level 1A and level 1B. How do we do that? So we use the medial margin of the anterior belly of digastric. So that's the anterior belly of the digastric. We use the medial margin of the anterior belly of digastric to divide level 1 lymph nodes into A and B. Any lymph node that is medial to that landmark is a level 1A node, and any lymph node that is lateral to that medial to that landmark is a level 1B lymph node. So level 1A and B are divided by these two anatomic landmarks. Then what about level 2 lymph nodes? So any lymph node that is posterior to the posterior margin of the sternum of the submandibular gland and is anterior between skull base and hyoid, of course. So we also use the superior-inferior landmark. So these lymph nodes are inferior to the skull base and are superior to the hyoid bone. So above the hyoid bone, below the skull base, and posterior to the posterior to the submandibular gland, and these are anterior to the sternocleidomastoid muscle. So in between the posterior margin of the submandibular and the posterior margin of the sternocleidomastoid muscle, and in between the skull base and the hyoid bone are the level 2 lymph nodes. Then these level 2 lymph nodes are also further divided into level 2A and level 2B. And for that, we are using the internal jugular vein. So lymph nodes that are anterior to the internal jugular vein, for example, this lymph node, that is a level 2A lymph node, and lymph nodes that are posterior to the internal jugular vein, but still anterior to the sternomastoid are the level 2B lymph nodes. So that is how we divide level 2 lymph nodes. Then level 3 lymph nodes, these lymph nodes are inferior to the hyoid bone, but superior to the cricoid cartilage. And in the cricoid cartilage, the landmark that we use is the inferior margin of the cricoid cartilage. So these lymph nodes are in between the hyoid and the inferior margin of the cricoid, and they remain anterior to the posterior margin of the sternocleidomastoid. So again, these are anterior to the sternomastoid. So these lymph nodes that we see here are level 3 lymph nodes, and level 3 lymph nodes are not divided into A and B. Then posterior, we'll talk about level 5 lymph nodes separately, but then these lymph nodes that are posterior to the posterior margin of the sternomastoid muscle are the level 5A lymph nodes. And we will see subsequently how level 5A and B are divided. What about level 4 lymph nodes? So level 4 lymph nodes are the lymph nodes that are inferior to the inferior margin of cricoid and are above the clavicle. So in between the cricoid and the clavicle are the level 4 lymph nodes. And these lymph nodes are anterior again to the sternocleidomastoid muscle, and these lymph nodes also include the supraclavicular, the anterior supraclavicular lymph nodes are included in the level 4. So these lymph nodes that are anterior to the sternomastoid, inferior to the cricoid, are the level 4 lymph nodes. Then again, posteriorly, you can see the level 5 lymph nodes, that are posterior to the sternocleidomastoid muscle. Then let's talk about level 5 lymph nodes. These level 5 lymph nodes have been cropping up in other levels too. So what are level 5 lymph nodes? So level 5 lymph nodes are the lymph nodes that are posterior to the posterior margin of the sternocleidomastoid muscle. So these lymph nodes right here, which are posterior to the sternocleidomastoid muscle, are the level 5 lymph nodes. And these lymph nodes are divided into 5A and 5B. And that landmark is the inferior margin of the cricoid cartilage. So the lymph nodes that are superior to the cricoid cartilage are level 5A, and the lymph nodes that are inferior to the cricoid cartilage are level 5B lymph nodes. What about level 6 lymph nodes? Level 6 lymph nodes are the lymph nodes that are medial to the medial margin of the internal carotid arteries. So any lymph node, tracheoesophageal lymph nodes, even Delphian lymph nodes are considered part of the level 6 group. So any lymph nodes that are, right here or in the tracheoesophageal groove are the level 6 lymph nodes. These lymph nodes are in between the hyoid and the sternum. So superior inferiorly, we divided lymph nodes that are between skull base and hyoid into level 2, and lymph nodes between the hyoid and the sternum in between the two carotids are the level 6 lymph nodes. Then level 7 lymph nodes are the lymph nodes that are in between the suprasternal notch and superior to the innominate artery. So any lymph nodes right here in this window are going to be the level 7 lymph nodes. So in this particular section, we divided, we completed our first objective, which was to review the different cervical lymph node levels. We still have the named lymph nodes, and if we still have time after I finish this review, I can take you to another presentation and we can review the named lymph nodes as well. But let's discuss features of cervical lymphadenopathy. So, how do we say whether or not a lymph node is abnormal on imaging? What are the different features that define abnormality uh, in a lymph node? And keeping that in mind, that on imaging we can only assess the lymph node so much. Even though a lymph node may look normal on imaging, it could still be abnormal. We are I'm reviewing this with the caveat that even normal lymph nodes can sometimes be abnormal on histology, and sometimes abnormal looking lymph nodes that sort of look rounded and we are suspicious about them may not be abnormal on histology. So even though we talk about all these abnormalities and different features on imaging, we are not at the end of the day 100% sure whether a lymph node is abnormal or not. Of course, if they have extranodal extension, if they look grossly abnormal, they are going to be abnormal. There is more likelihood of them being abnormal. But for smaller lymph nodes, these morphological features may or may not be really in concordance with the final histology reports. So what are the different features that we use for lymph node abnormality? So number one is, of course, the size. If the lymph nodes are really enlarged, we know that these lymph nodes are going to be abnormal. These lymph nodes are measured in long axis. So there are several different thoughts out there. Some people measure these lymph nodes in short axis. Some people measure them in long axis. In the body world, definitely lymph nodes are measured in the short axis, but a lot of people in the cervical region measure lymph nodes in the long axis. And these criteria that we talk about are usually the criteria for measuring these lymph nodes in long axis in the axial plane. So what are those criteria? Um, these criteria for level 2 lymph nodes is 15 millimeter, for retropharyngeal lymph nodes is 8 millimeter, and for all other groups, this criteria is 10 millimeter. So any lymph node that is more than 15 millimeter in level 2, any retropharyngeal lymph node that is more than 8 millimeter in the retropharyngeal region, and any lymph node other than level 2 that is less than, and that is more than 10 millimeter is considered abnormal. Again, level 2 lymph nodes sometimes are more than 15 millimeter and they don't look morphologically abnormal. And, commonly we pass them because they don't look abnormal morphologically, which is something that we are going to talk about. I mean, I did say that we measure the lymph nodes in long axis in the axial plane when we are trying to decide whether the lymph node is normal or abnormal. But there's one thing that we should keep in mind, that when we are staging head and neck cancer, at that point we are taking the greatest dimension of the lymph nodes, and that greatest dimension may not be in the axial plane. That greatest dimension may be in the coronal plane, maybe in the sagittal plane. So I'm going to talk about the different criteria, the size criteria that we use for dividing lymph nodes into N1, N2, and N3. So when we are doing that, in that case, we are measuring the lymph nodes in their greatest dimension. That at that point, we are not measuring them in the long axis, in the axial plane. We are measuring the greatest dimension of the lymph node when we are trying to stage these lymph nodes. So keep that in mind when we are talking about the size criteria of cervical lymphadenopathy. And again, when we talk about the borderline lymph nodes, when we talk about the criteria for abnormality, always remember that morphology of a lymph node, how a lymph node looks, is always going to be trump the size criteria. It's always going to trump the size criteria. So what are those, abnormal morphology features that are used for lymph node, for classifying a lymph node as abnormal? So a normal lymph node is going to be oval. Here's a very normal looking lymph node. These lymph nodes are usually oval in shape. They, you can call them reniform, kidney shaped, whatever. So these are oval, and they usually have this. Let me have this pointer. No, that's not what I wanted. Uh, okay, let's not waste time. These lymph nodes are are rounded and they have a maintained fatty hilum. So here's is a fatty hilum in the lymph node. So that is what a normal lymph node looks like. An abnormal lymph node is going to be rounded. It looks rounded and it loses that fatty hilum. So loss of fatty hilum and rounded shape is the criteria that is used for calling it abnormal. So this is a normal lymph node, but an abnormal lymph node is going to be rounded and is going to lose its fatty hilum. Then a normal lymph node is usually, again, you can see that this lymph node is oval in shape. That oval shape is the normal shape. And these lymph nodes are normally homogeneous in appearance. So on CT or MR, you're going to see that these lymph nodes are homogeneous, have homogeneous contrast uptake as well. But an abnormal lymph node is going to be very heterogeneous. And there are several features that could make it heterogeneous. They could be necrotic. So necrotic lymph nodes are always abnormal. You can see that this lymph node is not really enlarged. It is still small in shape. It is definitely less than 10 millimeter in the longest dimension, but it is rounded and shows central necrosis. So this lymph node, even though it's small, is definitely abnormal. It's a metastatic lymph node. And then cystic features, if a lymph node is cystic, again, it is abnormal. So it has lost its homogeneous appearance, and these lymph nodes are abnormal. And this, cystic lymphadenopathy can be seen with thyroid cancers or with HPV-associated head and neck cancers. Then these lymph nodes can also show calcifications, and these calcifications are commonly seen with papillary thyroid cancer. So, here is a papillary thyroid cancer, and you can see these abnormal lymph nodes that are calcified. So, calcification is also an abnormal feature which is used for determining whether a lymph node is abnormal or normal. Then what about the tissue adjacent to the lymph nodes? So in a normal lymph node, the adjacent soft tissue is clean. There is no infiltration of the adjacent fat. But an abnormal lymph node is going to infiltrate the adjacent fat. So if there is adjacent fatty infiltration, if there is haziness of the margins of the lymph node, then you know that you're dealing with an abnormal lymph node. So indistinct nodal margin or fatty infiltration is a feature of abnormal lymph node. If the lymph nodes show conglomeration, if there is matting of the lymph nodes, if two or more lymph nodes are matted together, that is also a feature of an abnormal lymph node. So conglomeration is a feature of lymph node abnormality. And if a lymph node shows frank invasion of the adjacent structures, there is invasion of the surrounding muscles, surrounding fat, vessels, or other surrounding soft tissues, then you know that you're definitely dealing with an abnormal lymph node that shows extranodal extension. And these three imaging features, indistinct nodal margins, conglomeration, and adjacent of the and invasion of the adjacent structures, are actually three grades of extranodal extension. So grade 1 extranodal extension is indistinct nodal margins with mild stranding of the surrounding fat. Grade 2 extranodal extension is lymph node conglomeration. And grade 3 extranodal extension is invasion of the adjacent structure. So when you see that, you know you're dealing with a grade 3 extranodal extension. So with this, we discussed features of cervical lymphadenopathy. What are the morphological or size features that make a lymph node abnormal? So in the next section, I'm going to be talking about, some causes of cervical lymphadenopathy, and I'm going to be discussing anatomic features that are pertinent to individual head and neck cancers. So here's just like a gestalt of what different causes can be for cervical lymphadenopathy. We can see cervical lymphadenopathy in different squamous and epithelial cancers of the head and neck. They can be enlarged in lymphoproliferative disorders like lymphoma and leukemia. They can be thyroid cancers that could present with cervical lymphadenopathy. Can be systemic malignancies, cancers that can present with supraclavicular lymphadenopathy or other cervical lymphadenopathy. Again, there can be other lymphoid disorders like Kimmerer's disease, Castleman disease that could lead to cervical lymphadenopathy. Tuberculosis, you know, definitely endemic in India, and is the most common cause for cervical lymphadenopathy, I imagine, in the Indian suppurative, and then infectious mononucleosis and other viral exanthems can present with cervical lymphadenopathy. But today what we are discussing is cervical lymphadenopathy in relation to the head and neck cancers, and end staging is the staging we use, the TNM classification, where we have the different end stage determinants for about the end is 3 centimeter, 3 to 6, and more than 6 centimeter So 3 and 6 is basically the size staging head and neck cancer. And again, there are different thoughts. Most people don't give a staging in their head and neck cancer reports. I myself don't head and neck cancers, but I give all pertinent features that could change staging in head and neck cancer. So when I'm talking about the T staging, I'm measuring that tumor with that in mind. That 2 and 4 centimeter is my size criteria for changing the T stage. In the same way, when I'm talking about lymph nodes in the head and neck, I keep this in mind that 3 and 6 centimeter is the size criteria for changing the stage of head and neck cancer. So with that in mind, I try not to be ambiguous and really give my surgeons adequate or accurate measurement so that they can adequately stage these cancers. So 3 and 6 centimeter is the size criteria that you should keep in mind when you are reporting head and neck cancers. Then another thing to keep in mind is whether you see a single abnormal lymph node or you see multiple abnormal lymph nodes. And then, always look on the other side of the cancer and make sure that you're not dealing with bilateral or contralateral lymphadenopathy, because that also changes the end staging. And then, of course, you definitely have to look for extranodal extension. Extranodal extension is very, very important because extranodal extension, even if a single lymph node that is, less than 3 centimeter in size, even less than 1 centimeter in size, shows extranodal extension, that puts that end staging at the highest clinical nodal stage, which is N3B. So always look for extranodal extension because that is going to upstage your cancer. Yeah, that's the highest clinical stage. So for all cancers other than HPV, so let's talk about these, end staging in different head and neck cancers. So when we are talking about all squamous cell cancers in the head and neck, besides the viral associated cancers, so there are two viral associated cancers. We have the HPV associated head and neck cancer that is most common in the oropharyngeal region, and then we have the EBV associated head and neck cancers, which are most commonly seen in the nasopharyngeal region. So if you exclude those two, HPV and NPC, for all other cancers, this is the general staging criteria and staging criteria that we use. So single ipsilateral lymph node that is 3 centimeter or smaller. So if you see a single lymph node that is less than 3 centimeter on the same side of the cancer, then that is usually, and then that is the N1 stage of the cancer. If you see a single ipsilateral lymph node, so single lymph node that is on the same side where the cancer is, which is more than 3 centimeter but less than 6 centimeter, then that is a N2A staging in terms of end staging for the cancer. So single lymph node on the same side, 6 centimeter. Then if you see multiple ipsilateral lymph nodes, so there are multiple lymph nodes that are on the same side as the cancer is, but all the lymph nodes are less than 6 centimeter, then that is N2B staging. And then when you have bilateral or contralateral lymph nodes, so bilateral lymph nodes or lymph nodes on the other side of the cancer that is less than 6 centimeter, that is N2C staging. So this is N1 and N2 stage, and two stages further divided into lateral lymph nodes, multiple ipsilateral lymph nodes less than 6, all lymph nodes in N2 stage, and then you have to see whether there are multiple ipsilateral or contralateral or bilateral. Any lymph node that is more than 6 centimeter, that becomes N3A. So N3 means or more than 6 centimeter means that the end staging is already in the N3 stage. And then there is extranodal extension. When there is extranodal extension, that is the highest nodal stage, which is N3B. And we talked about the different features of extranodal extension. It could be indistinct nodal margins, it could be lymph node conglomeration, or it could be frank invasion of the adjacent structures. Then what about HPV cancer? We excluded HPV and NPC when we were talking about the staging. So what about HPV cancer or P16 associated cancers? So for this, the size criteria is 6 centimeters. So we talked about 3 centimeter and 6 centimeter in cancers. that are non-HPV associated. But in HPV associated cancer, there is only one size criteria, that is 6 centimeter. So whether lymph nodes are single or same side as the cancer, then that is N1 stage. For HPV cancer, we don't divide N2 stage into A, B, and C. So any lymph node that is less than 6 centimeter, if it's contralateral or bilateral, that is N2 stage. So multiple lymph nodes on the other side or single lymph node on the other side that is less than 6 centimeter, that is N2 stage. And then if you have lymph nodes that are more than 6 centimeter, then that is the N3 stage for HPV associated cancers. Then what about nasopharyngeal cancer? And nasopharyngeal cancer, recently, AJCC ninth version has already come out for nasopharyngeal cancers, and they have slightly tweaked how nasopharyngeal cancers are staged, and I'm going to talk about that a little bit here as well. So what do we do in nasopharyngeal cancers? So in nasopharyngeal cancers, unilateral cervical or unilateral or bilateral retropharyngeal lymph nodes that are less than 6 centimeter is the N1 stage. So unilateral, that means, on one side, cervical lymph nodes, or bilateral retropharyngeal lymph nodes, unilateral or bilateral cervical lymph nodes, again, less than 6 centimeter, that are above the cricoid. And again, inferior margin of the cricoid is the landmark. So all these lymph nodes that are above the cricoid, uh, unilateral cervical or unilateral or bilateral retropharyngeal, that is N1 stage. Then bilateral lymph nodes, again, less than 6 centimeter above the cricoid, as long as they're above the cricoid, whether or not they are bilateral or contralateral. If they're less than 6 centimeter, that is the N2 stage. And then N3 stage is when you start seeing lymph nodes below the cricoid cartilage. So lymph nodes below the cricoid cartilage, if the lymph nodes are more than 6 centimeter, or if the lymph nodes show extranodal extension. And here, we talked about the different grading of extranodal extension, grade 1 being indistinct margins, grade 2 being lymph node conglomeration, and grade 3 being frank invasion of the adjacent structures. Grade 3 ENE actually is the only ENE that is relevant for N3 staging of nasopharyngeal cancer. So if you see grade 3 ENE, only then you grade it into N3 stage for nasopharyngeal cancer. So that is something that has changed in AJCC ninth version. So you have to look for frank invasion of the adjacent structures when you talk about N3 staging in nasopharyngeal cancers. With this, lymphadenopathy, and we discussed anatomic features pertinent to different cancers. I want to thank you, and I want to see if we have uh, enough time to, well, it's already 9. Do we have time to go over the named lymph node levels, Kajri?
Yes, yes, yes. We have times. It's half an hour only since we have started the webinar, so we can have another 10-15 minutes for sure.
Okay. Okay. So let me share this. All right. So here we talk about the other nodes. So as I said, we have the different level lymph nodes, but then we also have, other lymph nodes in the head and neck. And so let's not go into this. Let's talk about the nomenclature of the other nodes. So we talked about the different lymph nodes that are not named. So we have, retropharyngeal lymph nodes that are in the retropharyngeal space. We have the parotid and the pre-auricular lymph nodes that are in the parotid space. So any lymph node in this particular region, that is the parotid and pre-auricular lymph nodes. We have the retromastoid lymph nodes that are sort of superficial to the sternocleidomastoid muscle. So around the sternocleidomastoid muscle, those are the retromastoid lymph nodes. We have the occipital lymph nodes. We have the facial lymph nodes that are along the facial vessels in the face. And then we have, again, a level showing retropharyngeal, parotid, preauricular, the occipital group. The facial group that extends from the mandible up to the medial canthus of the eye around the facial vessels. Those are the facial lymph nodes. And then we have the Delphian lymph nodes, which are the prelaryngeal lymph nodes. And then we have the superficial cervical lymph nodes that are along the external jugular vein, not the internal jugular, but the external jugular vein. Those are the superficial cervical. So let's talk about these, different lymph node levels, the name levels. So prelaryngeal or Delphian lymph nodes, typically they're classified as the lymph nodes that are in the cricothyroid gap or in the cricothyroid membrane, but practically any lymph node that is in the midline in that region is taken to be as a Delphian lymph node. Delphian lymph nodes basically drain the larynx and the thyroid, so they can be seen with thyroid and laryngeal malignancies. And they drain out into the lateral cervical lymph nodes. So why are these lymph nodes important? These other lymph nodes can become sites for nodal metastasis in head and neck cancer, but the circumstances for their involvement is usually unusual. A Delphian lymph node or lymph nodes in parotid lymph nodes, they get involved when there is distortion of some kind of lymph node drainage pathway. So when we look at these lymph nodes, when we see enlarged lymph nodes, Delphian lymph nodes, for example, then we are more worried because this kind of lymphadenopathy is associated with worse outcomes. They have increased incidence of metastasis, not only in the lateral cervical lymph nodes, but also elsewhere in the body. And they also have an increased incidence of local recurrence when we see abnormality or abnormal Delphian lymph nodes. And, in Delphian lymph node, positive patients, some surgeons suggest that they should be lateral lymph node dissection. So, for example, you have a thyroid cancer or a laryngeal cancer that only has enlargement of a Delphian lymph nodes. Surgeons say that when there is Delphian lymph node abnormality, they routinely perform lateral lymph node dissection, even though they might not see any abnormal lymph nodes in the cervical chain. So, that way, because these lymph nodes are associated with worse outcomes. So here are some examples of Delphian lymph node enlargement. Here is a Delphian lymph node that is enlarged in a person who's had prior thyroidectomy. And again, when you see this kind of lymph node enlargement in a person who's being followed up for thyroid malignancy, you know that this is site for lymph node recurrence. Then here we have a Delphian lymph node enlargement in a person who has been treated for oral cancer. So this was a tongue-based cancer, and this person had recurrence of cancer in a Delphian lymph node. You can see here. So Delphian lymph nodes are usually not part of the routine cervical lymph node dissection. When patients have oral malignancies or tongue-based malignancies, it's the lateral lymph nodes that are usually dissected. So these lymph nodes then become sites for recurrence because these are the only lymph nodes that are persistent or remain there for any kind of lymph node drainage. So they can become sites for local recurrence. So here we have Delphin lymph node recurrence in a person who's been treated for oropharyngeal cancer previously. This is another patient who has an enlarged Delphin lymph node, and you can see that this patient has also been previously treated for oral cancer, for floor of mouth cancer. And here we have, a thyroid malignancy that has an enlarged Delphian lymph node. And in this case, even though this patient might not have lateral lymph node metastasis, a routine lateral lymph node dissection is going to be performed because, there are chances of lateral lymph node positivity in these patients. Retropharyngeal lymph nodes, the retropharyngeal lymph nodes extend from the skull base to the hyoid bone. They are in the sort of the retropharyngeal space. There are medial and lateral groups. Medial groups are not normally seen in adults. You can see them in children, but lateral lymph nodes can be seen. Large lymph nodes can be seen in different pathologies, oropharyngeal cancers, nasopharyngeal cancers, most importantly, and then they can also be enlarged in infectious or inflammatory disorders. And these retropharyngeal lymph nodes are actually very important. These lymph nodes are your lymph nodes. These are radiologists' lymph nodes because these lymph nodes are not amenable to palpation. So you will be the only person who will alert your physician, your doctor, your oncologist about retropharyngeal lymphadenopathy. So pay very close attention two retropharyngeal lymph nodes when you are looking at images for head and neck cancer, especially nasopharyngeal oropharyngeal cancers, because you're the only person who see them and can alert your physician. And the management is definitely going to change if a person has retropharyngeal metastasis. So always pay attention and try to report retropharyngeal lymphadenopathy if it's present. Then nasopharyngeal cancer, of course, is the most common malignancy that metastasizes to retropharyngeal lymph nodes, but there, all kinds of head and neck cancers can metastasize there. Oropharyngeal, sinonasal cancers and other cancers. Thyroid cancers can also commonly metastasize to retropharyngeal lymph nodes. The lymphadenopathy is associated with poor survival, and it definitely changes management. And if they are treated, then of course it improves survival. Then here's an example of retropharyngeal lymphadenopathy. You can see enlarged retropharyngeal lymph nodes bilaterally here in this case in a person with nasopharyngeal cancer. And as we saw previously, lymph node retropharyngeal lymphadenopathy is the N1 staging for nasopharyngeal cancer. Then retropharyngeal lymph nodes, as I said, can be enlarged in all malignancies. And here we have an oropharyngeal ulcerative cancer, and you can see bilateral necrotic retropharyngeal lymphadenopathy. This is, it's very important to report these lymph nodes in these patients because it's definitely going to change management. Here again, we have bilateral necrotic retropharyngeal lymphadenopathy in a person who is being followed up for head and neck cancer. This person has already had treatment for head and neck cancer. You can see all these treatment changes, and this person presented with recurrence of head and neck cancer in the retropharyngeal lymph nodes. So again, very important to look at these lymph nodes even during follow-up. Then suppurative adenitis, of course, there can be other causes for retropharyngeal lymphadenitis. Suppurative adenitis in kids is definitely one of the things which has to be differentiated from retropharyngeal abscess, which usually is bilateral, sort of spreads like a fluid. And retropharyngeal abscesses are basically, rupture of these suppurative lymph nodes into the retropharyngeal space. Then occipital lymph nodes, there are several different kinds of occipital lymph nodes. They usually drain the scalp of the occipital region, and they generally drain into the level 5 lymph nodes, but can also drain into the level 2 lymph nodes. They could be suprafascial, which is, outside you have a fascia here, so they are above the fascia, so suprafascial occipital nodes. They can be subfascial, so that's the fascial layer. So they could be subfascial, or they could be submuscular. So this is a lymph node that is under that muscle plane that is in the occipital region. So three different kinds of lymph nodes. Again, submuscular lymph nodes, I think, are very sort of difficult to diagnose, difficult to see, because when you see a lesion here, you could think that this could be like a muscular lesion, or this could be a soft tissue abnormality. But always keep in mind that submuscular lymph nodes actually live there. And if you're following a case for head and neck cancer, or if you're following a scalp cancer case, or looking at a scalp cancer case, then remember that submuscular occipital lymph nodes actually live there, and you could simply be looking at metastatic lymphadenopathy. And here's an example. Here this person has a fungating scalp mass, and you see these enlarged occipital lymph nodes. Here we have a suprafascial enlarged occipital lymph node with extranodal extension that is also involving the subcutaneous tissue and the skin. Then parotid lymph nodes, again, you can have intraparotid, periparotid lymph nodes. Parotid lymph nodes, lymph nodes in the head and neck actually develop before the development of the parotid gland. And when the parotid gland develops, it sort of envelops or engulfs all these lymph nodes that are already developed in the head and neck. And that's why you have so many intraparotid and periparotid lymph nodes. These lymph nodes drain the skin from the parietal scalp, from the frontal scalp, from the external auditory canal, and from the zygomatic part of the face. And these lymph nodes usually drain into the upper cervical lymph nodes. These lymph nodes can be enlarged in, scalp cancer. So here we have a necrotic preauricular lymph node. that is, metastasis from scalp cancer. And these lymph nodes also have different names. So this is a preauricular lymph node. You can have superficial parotid lymph nodes. Deep lymph nodes that are usually adjacent to the parotid tail. So these are the different sort of classifications of the parotid lymph nodes. They can be enlarged in systemic malignancies. So again, all the lymph nodes that we are talking about, whether these are lever lymph nodes or named lymph nodes, can be enlarged in two kinds of scenarios. They can be enlarged in systemic malignancies, and that is also true for these named lymph nodes. So here we have an example of a parotid lymphadenopathy in a person who has CLL, and then these lymph nodes can be enlarged in local malignancy. So scalp cancer can lead to, whatever their draining area is, they can be enlarged in local malignancy. So this is a frontal scalp cancer patient with a pre-auricular necrotic lymphadenopathy. Then they can also be enlarged in parotid malignancies. So parotid malignancies can definitely drain into the parotid lymph node. So here's an example of that. Then retroauricular or mastoid lymph nodes, they are behind the mastoid. They are superficial to the sternocleidomastoid muscle. They drain the tragus, the pinna. They can drain the parietal scalp, the occipital scalp, and also the upper neck skin. So that's the drainage area for the occipital lymph nodes. And they drain into the upper lymph nodes, level 2s and level 5s. Again, they can be enlarged in systemic malignancies like CLL, or they can be enlarged in local scalp cancers. Facial or buccal lymph node extends, from the mandible to the medial canthus of the eye along the facial vessels. They drain, skin around the eyes, skin from the nose, upper lip, from the facial region, and they drain into the parotid and the upper cervical lymph nodes. So these buccinator group of lymph nodes actually drain into the parotid lymph nodes. So again, different kinds of cervical lymph nodes. They can be mandibular, lower down adjacent to the vessels. They can be buccal, as you come further up along the facial vessels, they can be buccal or buccinator group. Then they can be malar lymph nodes, in the malar region, or they can be infraorbital lymph nodes in the infraorbital region. Then the different scenarios where these lymph nodes can be enlarged: Merkel cell carcinoma around the eyelids can lead to facial lymphadenopathy. Here we have a malar group of lymph node enlargement in two different cases of Merkel cell cancer. Here we have a facial lymph node that is enlarged in lymphoma. So again, systemic malignancies can lead to cervical lymphadenopathy, and even these smaller lymph nodes can be enlarged. Then superficial cervical lymph nodes that are along the external jugular vein, all along the neck. They drain the skin of the neck. And these again can be enlarged in local skin malignancies. So here we have different lymph nodes along the external jugular chain, along with level 2 and some level 1 lymph nodes, level 1B lymph nodes. Then what are the common scenarios? I've been talking about that a little bit. What are the common scenarios where we can see other lymph node enlargement? So regional cancers, regional cancers can lead to lymphadenopathy in these smaller nodes. So parotid lymph node cancer, lymphadenopathy from skin cancer. They can be seen in recurrent cancers. So I talked about the Delphin lymph nodes that can be, or the retropharyngeal lymph nodes that can enlarge in recurrent cancers. So lymph node cancer recurrence can be seen in these lymph nodes that are not part of the routine neck dissection. So they're left behind, and they can be sites of cancer recurrence. And then, of course, they can be enlarged in systemic malignancies. Then when to call it, we've talked about that at length. When is a lymph node abnormal? Morphology tends to trump size, and there is not usually a very good size criteria for these other lymph nodes. So morphology really is your friend to call a lymph node abnormal in these areas. If a lymph node is rounded, has loss of fatty hilum, if it's necrotic, and especially if it's asymmetric in this region, you should really pay attention whether or not this lymph node is abnormal. Then what to do if you're unsure? In the level lymph nodes, usually the level of surety is slightly greater, but in these smaller lymph nodes, you're left wondering whether you're looking at an abnormal or a normal lymph node. So, for example, here, this lymph node has some endostic margins, is in the preauricular region. I was following this patient for a skin cancer, and I wasn't sure. I just said, this is indeterminate, maybe get a PET. And lo and behold, they got a PET, and this lymph node, which looked small but slightly abnormal, was actually a positive metastatic lymph node. So PET usually is your friend when you're trying to decide whether a lymph node is normal or abnormal. So here's again sort of an overview of different other lymph nodes. They can be delphin lymph nodes, very important, really change prognosis. Retropharyngeal lymph nodes, you should always look for them. They are your lymph nodes. You are going to be the person telling your surgeon about these lymph nodes. It can change management if you call retropharyngeal lymph nodes. Then occipital lymph nodes can be enlarged in skin malignancies, systemic malignancies. We have parotid lymph nodes that are commonly enlarged with systemic malignancies and parotid cancers, retromastoid, facial lymph nodes. Always look out for them. I recently saw a case of a facial lymphadenopathy from a parotid cancer. I actually also posted it on the WhatsApp Cortex Club group. They had a big parotid cancer with a perineal tumor spread and an enlarged necrotic facial lymph node. Then superficial cervical lymph nodes, and then you can have multiple lymph nodes in systemic malignancy. So for these smaller lymph nodes, always look outside the level 1 to 7 system because, if you find these lymph nodes, it's definitely going to change management. These lymph nodes, especially look for them when you're following up these patients, especially following up scalp cancer patients, or, look at delphin and retropharyngeal if you're following up other head and neck cancers or post-radiation. Metastatic lymph nodes, as you know, they worsen prognosis. They definitely change the course of treatment. They have to be dissected or included in the radiation field. Here are my references, and again, I want to thank you all for listening patiently.
Thank you so much, Dr. Mohan.